Universidad Central de Venezuela, and then completed an internal medicine residency at Mount Sinai Medical Center in Miami Beach, followed by a fellowship in infectious diseases at the University of Miami Jackson Memorial Hospital. She is currently the Chief of Infection Control and Prevention and Antimicrobial Stewardship at Jackson Memorial Hospital, and is the author of multiple book chapters and peer-reviewed articles, primary investigator as well for several award-funded research projects. She has lectured in multiple venues, both locally in the U.S. and internationally, and is the recipient of numerous awards. Today, she'll be talking about management of multi-drug resistant gram-negative infections and its challenges. Please join me in welcoming today Dr. Lillian Alba.
Good afternoon. Thank you for the kind invitation, and it's a pleasure to be here. In the next 25 minutes, I'm going to try to keep you all awake, and if I see anybody sleeping, I'm going to call your name and ask you a question. I'm kidding. So the current objectives of today, I hope you will appraise what are the current trends in antimicrobial resistance globally and locally, what are the current treatment options that we have in some of our challenging cases, and then what's in the pipeline, and what are other alternatives that we can look at. So let's start with a case. We have a 54-year-old lady who just came back from a 3-week vacation in Asia, and she comes to your clinic with a 2-day history of dysuria and fever. She took 10 days of antibiotics for a sinusitis 5 months ago. It's a white pill. She can't remember which one. And you diagnosed a urinary tract infection. And my question to all of you is, raise your hand. How many of you are even concerned about antibiotic resistance in this patient? Okay, not too many. So do you think you're human? And there are about 7.6 billion people in this planet estimated to live on Earth by this year, 2018. However, each one of us has about 100 trillion bacteria in our bodies. So the size of our GI tract is about 2 tennis courts, and the number of bacteria compared to our human cells are 10 to 1. So pretty much you're walking microbiomes. And thanks to the miracle drugs of the 21st century, antibiotics, we're able to do miracles every day. We're able to take care of very sick people in our ICUs. We're able to take care of premature babies that otherwise would have died decades ago. We're able to do solid organ transplants, do amazing bone marrow transplants, give chemotherapy, and treat meningitis when, 100 years ago, people were dying from these diseases. However, the appropriate and inappropriate use of antibiotics has consequences. And the WHO, as of last year, published the top 3 organisms where we urgently need new antibiotics. And they're all Carbapenem resistant: Enterobacteriaceae, Pseudomonas, and Acinetobacter. And if you have not rounded recently at Jackson, we have pretty much all of them. What is the distribution of Carbapenem-resistant organisms in the United States? If you look at this map, in the spring of 2007, this was the map. We had a couple of series, sporadic in Florida and other parts of the country. And if you look in red, the Northeast, New York, this was endemic. Pretty much many hospitals, or all hospitals in New York, were experiencing Carbapenem-resistant organisms in their ICU. But look at what happened in 10 years. This is January 2017. The only 2 states that had not reported CREs were Maine and Idaho. Maybe it's in the potatoes, right? But no, by December of last year, this is the map. Every single state in the country has reported Carbapenem-resistant Enterobacteriaceae. So this is a problem. It's not isolated to your medical ICU across the street, or here at Jackson, or at the UM or VA. It's not isolated to Miami. It's not isolated to the US. This is a global problem. And the world is flat. People travel. We're globalized. We're no longer in one place. We eat food that comes from anywhere in the world. We can travel anywhere we want. And if we don't do something about this problem, the estimated deaths related to antimicrobial resistance by the year 2050 are going to be 10 million people. Every 3 seconds, somebody will die secondary to antimicrobial resistance if we just do what we're doing today. This is a larger number than the number of people with diabetes, number of people dying with cancer, number of people dying from road traffic accidents. And this is going to cost us about $100 trillion to the GDP. So what are some potential sources of antibiotic resistance, and what can we do about them? So every year in the United States, we're consuming about 17 million kilograms of antibiotics. And 80% of those antibiotics are being given to animals. In the 1950s, it took about 70 days to grow a chicken. By 2008, the same chicken has twice the size and grows in half the time. And guess who's eating all those fluoroquinolones? Anyone who's not a vegetarian in this room, pretty much. Pets, huge abuse of antibiotics in aquaculture, in agriculture, and about 20% of antibiotic use are being given to humans. And out of those, we know from our data and published data that about 30 to 50% is in hospitalized patients, and up to 50% of antibiotics we prescribe outpatient or inpatient are inappropriate or unnecessary, too broad spectrum, too long duration, or we're simply writing off a prescription for a viral infection because it's just easier than counseling the patient. And we think that ampicillin is just a narrow spectrum antibiotic that only covers listeria, gram-positives, gram-negatives, right? So we think that, a Z-Pack causes no harm. So sorry to tell you, but we're wrong. Antibiotics also cause prolonged alterations in your gut flora. So if you look at the end of the chart, we need a diverse microbiome, like we need a diverse group of faculty or residents in our, in our department. This diversity is healthy, but when we take an antibiotic, we cause dysbiosis. And that dysbiosis may cause genetic transfer of resistance. And bacteria are very, very promiscuous. Bacteria don't need to stay 9 months pregnant. They don't need to have sex with another, E. coli. They can share resistance genes with, interspecies. So a Klebsiella can get a resistance gene from an E. coli, and so on and so forth. And then once you have this resistance gene transfer and you continue the use of antibiotics, you're going to see in purple the oligodomination. There is a predominance of one species, and that's when we have infection, and that's where we are in trouble. That's when you have your pneumonia and you can't get rid of that Pseudomonas. So it takes about 2 years, according to some studies, to restore that diversity in your gut microbiome. There is also a study, this didn't come out well, but there's a recent study that looked at the incidence of graft versus host disease and mortality in humans and mice that got allogeneic bone marrow transplants and then developed GVHD. And what these investigators found was that there was increased GVH-related mortality after 5 years in patients that received broad-spectrum antibiotics for neutropenic fever, 21% with imipenem compared to 13% untreated, and 20% with pip/tazo compared to 12% untreated. But they didn't see this association with aztreonam or cefepime. So you could say, well, maybe the sicker patients got the broader spectrum antibiotics. But what they're looking in mice is that perhaps imipenem is suppressing your anaerobic commensals. And that may be disrupting the lining of the colon, and perhaps that's what is causing this severe GVHD. So this is now at Sloan Kettering undergoing a prospective randomized study, trying to better understand if the incidence of GVHD is associated with the broader the spectrum of the antibiotics we're using. So think of that, right? These are the most common antibiotics we use when somebody's critically ill or septic, and perhaps as we're treating one problem, we're causing another. You also need to understand that gram-negative bacteria have about 7 mechanisms of resistance. And when we need to pick an antibiotic, we need to understand which organism are we treating, what's the most likely mechanism of resistance that bacteria might be expressing, and how can we overcome it in order to treat that infection. So for today, it's impossible in 30 minutes to cover every single mechanism of resistance, but I'm going to focus a little bit on what are the most common ones related to beta-lactamases. So at the far right, you have the extended spectrum beta-lactamases, or your ESBLs, most commonly expressed by E. coli and Klebsiella. Then in the middle, you have your AMC, which we have the space organisms, and then the Carbapenemases, which I'm going to talk a lot more today. And the Carbapenemases are 3 classes. A, your KPC, which are the most common one, the most prevalent in the United States. The B are the New Delhi betallolactamases, and the D are the oxatypes. So the first question I posed when I started the talk was, this lady had a UTI, had traveled, and had a recent sinus infection and was given antibiotics. So in this study, they look at what are the independent risk factors for community-acquired ESBL-related infections in UTIs. And if you have taken an antibiotic in the last, if you have traveled to the Middle East or Asia or Africa in the last 6 weeks, your odds ratio is about 21. So Traveling increases your risk of acquiring resistant organisms. If you have taken fluoroquinolones in the last 90 days, and fluoroquinolones are pretty commonly prescribed for sinus infection, well, guess what? Your odds increase to 16. And if you have taken any beta-lactam, it's about 5. They also comment that if you eat fish, and depending on how many times a week you eat fish, your odds increases. I don't know the correlation with fish. Other studies have looked at what is the fecal colonizations of patients. So let's say you're a healthy subject. What are the chances of you being colonized with one of these resistant bacteria? So they took a systematic review of 66 studies. They took about 28,000 healthy subjects. And what they found in these healthy people is that about 14%, so it could be any one of us in this room, can be colonized in your gut with extended spectrum beta-lactamases. And the most common ones were actually CTXMs. Particularly if you come from Asia, 46%. The higher risk of colonization was anyone who had taken an antibiotic in the last year, or anyone who had traveled internationally. And then ESBL colonization, it's pretty significant worldwide. So this has significant implications for antimicrobial stewardship, because now when you have somebody, you have to prescribe an empiric antibiotic while you wait for your cultures, you need to take some of these things into consideration. We also have to take precautions in infection control because we know these genes spread very easily. So when we don't wash our hands, we're pretty much transmitting this to each other. So what are some of the options? And I'm not going to go into detail, but I really want you to take home today that whenever you're going to treat an infection, you need to think of what's the site of the infection, what is the minimum inhibitory concentration when you have your culture results, and then figure out what is your priority. And you can't treat everyone the same. If you're treating a respiratory infection, it might be very different than treating a kidney transplant with a urinary tract infection. You may want to avoid aminoglycosides in those patients. So based on this, we have different recommendations, but for ESBL, pretty much carbapenems or aminoglycosides are our first choice. If you're treating an uncomplicated urinary tract infection, fosfomycin might be an option. And I'm going to go a little bit into how each antibiotic works later on. So our second case is a 35-year-old lady who had Gardner syndrome. And for those of you who don't remember, Gardner syndrome is it's a relatively benign desmoid tumors, but they metastasize and they end up acting like a very invasive malignant disease, even though these tumors are not malignant. And they occur only in 2 to 4 people per million per year in the United States. So she comes in with short gut syndrome and is referred to us for an intestinal and kidney transplant. And she undergoes transplant, and on post-op day 20, she's febrile, in septic shock, and blood cultures have 2 out of 2 gram-negative rods. And we get moleculars that say it's a Klebsiella pneumonia, it's a carbapenemase producer, but not a KPC. And this is the susceptibility. So how would you treat our patient? Would you give them Colistin, Carbapenem and Colistin, 2 Carbapenems and Colistin, tigacycline, Colistin, and a Carbapenem, Colistin, Carbapenem, and Fosfomycin, contact precautions and prayers, try all the above, and if everything fails, get an ID consult. So this is a nightmare. And the first thing you have to do is call infection control and really break the chain of transmission, okay? We have a Jackson enhanced contact precautions for this type of patients. That means we cohort one-on-one nursing whenever possible. And every caregiver, nurses, radiology, wherever you're moving that patient, family members need to be extremely educated that this is a highly contagious, transmissible, multi-drug resistant organism. So that's the first step. Now, how do we manage this? Is there a cookbook, right? Give me the recipe, so every time I see some of these, I know what to use. But the problem that we have is there is no magic recipe. Each patient is different. And there is some evidence on how to treat these infections, but it's mostly from few heterogeneous randomized trials, some case series, and the majority of the studies are actually observational. And what we know prior to the new antibiotics is that the data shows that when you combine antibiotics for these carbapenem-resistant organisms, is much better, your survival, when you give inappropriate therapy or when you give colistin monotherapy. The Spanish group recently published their consensus recommendations in how to manage these infections, and for mild infections with fully active drugs, they recommend monotherapy, but for severe and multi-drug resistant infections, the recommendation really is first-line combination therapy with at least 2 active agents depending on the MIC, and then you streamline depending on your susceptibilities. Now, when can we use carbapenems in carbapenem-resistant organisms? Always in extended infusion, always in combination, and only if the minimum inhibitory concentration of the organism is less than 8. If it's more than 8, Carbapenems are not going to work. And there's some proposed treatment algorithms. I'm not going to go into detail. You can look at the reference, but pretty much less than 8, we can use a carbapenem with prolonged infusion in combination usually with an aminoglycoside or with colistin. And if it's more than 8, it will depend if it's colistin susceptible or colistin resistant. So how does colistin work? Colistin is a drug that was, created decades ago. It was taken out of the shelves because it was extremely nephrotoxic. And then when we started to see in the early 2000s, Acinetobacter and some of the Pseudomonas multidrug resistance, then colistin was started to be reused again. And nobody really knows how to dose it very appropriately. But it pretty much acts in the outer membrane. And if you remember, your gram-negatives are a little different than your gram-positives. So here's where colistin is going to act. And it really acts as a detergent. It starts washing off that cell membrane and allows other antibiotics to penetrate and kill the organism. It also has a very potent endotoxin activity. So you always need to use a loading dose. You need to renally adjust it and expect to see between 20 and 70% of nephrotoxicity. Other drugs that are available are fosfomycin. And fosfomycin is very broad spectrum, has high bioavailability, distributes very, very well in different tissues, including the brain and the bones. And for urinary tract infection is where it has been studied the most. The problem is that when you use it, we see rapid development of resistance. And for serious infections, it should never be used as monotherapy. So if it's a uncomplicated UTI, a cystitis, it works. But if you're treating something more serious, like a bacteremia, osteomyelitis, etc., it should never be used as monotherapy. In the US, it's currently available only in the oral formulation, and it's one dose, one sachet every 3 days, single dose for UTI. For prostatitis, you might take up to 21 days every 3 days. Now, the good news is that there is a company that already is working on manufacturing here in the United States. It's called Zavante, the brand name. And for that, you currently need an IND and an IRB. We have obtained IRBs and INDs to use it. So if you need compassionate use, it's available now in the US. Up to December, it wasn't. Warning, when you use the IV product, it has a very high concentration of sodium, so you have to avoid it in patients with heart failure. Tigacycline is another drug that has been around for decades. It's a very broad spectrum tetracycline. It's mostly bacteriostatic. And the problem that we have with this drug is there's a black box warning. It's really very poor concentration in blood. So if you should not use it for patients who are bacteremic. You might need to use higher doses. The standard dose is 50 Q12. But for these multidrug resistant organisms, or depending on their septic shock, we might need to use higher doses. Dual carbapenems is another option we have tried, and it's when you're desperate and you have nothing else to use. So how does dual carbapenems work? And the first time I heard this, I thought it was crazy, right? Because it's not what we hear in medical school. It's not what's on the textbooks. But the way this works is like a kamikaze. So pretty much you're sending the ertapenem to saturate all your enzymes, and then you allow the meropenem or the other carbapenem to pretty much kill the bacteria. So the ertapenem is suicidal. And does it work? Well, there is data in vitro when you have used a combination of doripenem plus ertapenem. There is superior time to kills when the control or when you use ertapenem or doripenem individually alone. And there are several case reports, including one from Dr. Camargo, who's here in the audience, in our group, looking at different combinations with dual carbapenems. The problem with this is that in the majority of the studies, they have seen relapsing bacteremia. So use it if you have no other choice, if you're practicing in a part of the world where there are no other antibiotics. So what are the new drugs? And if there's one only thing you're going to take out of this talk today, is that we do nothing creating new antibiotics if we don't have antimicrobial stewardship. Developing new drugs without having good stewardship or mechanisms to ensure that we all prescribe appropriately is like giving your alcoholic a different brand of brandy. So what are the new cephalosporins? We have ceftolozane tazobactam. It has been around already for almost 4 years. It has a very enhanced anti-pseudomonal activity. So for carbapenem-resistant pseudomonas or even colistin-resistant pseudomonas, we have been able to use this drug, usually in combination. It does not have activity against the class B carbapenemases, so the metallobeta-lactamases, but it does have activity against KPCs and OXAs. And in a multi-center evaluation that we participated, there were about 35 patients already treated with this drug. 74% were successful, had successful outcomes. The most common infection was pneumonia, but the outcomes are more likely to fail if you have a high MIC greater than 8. Other cephalosporins, this is not yet available in the market, it's Cefderichol. Cefderichol is a novel siderophore, and it's very promising. It will have activity against Carbapenem-resistant Acinetobacter and metallo-beta-lactamases. So this is huge because so far we have no drugs to treat these organisms. The only problem is that it's pending clinical trials. All of this is in vitro data. The other good news is it has no anaerobic or gram-positive activity, so potentially it will be better for your biome and less likely to cause C. diff. Other drugs that we currently have available are ceftazidime avibactam and meropenem barbobactam. Avicaz is ceftazidime plus has ESBL, AMC, KPC, and OXA activity, but it doesn't have metallo-beta-lactamase activity. So you have to also avoid monotherapy. And meropenem barbobactam was just approved August of last year for complicated UTIs, pyelonephritis, or any organism causing a carbapenem resistance. Again, it says in vitro that it's more potent than Avicaz, but not acting against MBLs. We've used it recently in December in one patient with Pseudomonas. We didn't see much improvement, even though it was susceptible in vitro, developed resistance in vivo after a few weeks of therapy. Aztreonam avibactam, imipenem relebactam, and ceftaroline avibactam are all coming up. They're not yet available. They're on their phase 2 or phase 3 trials. None of them, the most promising one, I think, from the top is the top one, the Aztreonam avibactam, because it will have activity against not just the KPCs and the OXAs, but also the MBLs. And the other two are pretty much what we have presented so far. Ceftaroline also has activity against Staph aureus MRSA. New aminoglycosides, plasomycin, is a new drug that is coming up. It's not active against the new delis, but it's very potent activity, potentially against Enterobacteriaceae and also against Pseudomonas. And there are two phase 3 trials that have been finished. In both of them, in the first one, the modified intention to treat was superior plasomycin compared to meropenem in patients that had multidrug-resistant organisms. And in the second one, with bloodstream infections and pneumonia, Plaso versus Colistin in combination with meropenem or tigacycline, better survival with plasomycin, less mortality, and less nephrotoxicity. Other tetracyclines coming up, it's everacycline. It's a bacteriostatic drug, but it's apparently bactericidal against Acinetobacter, and it's also undergoing phase 3 trials. So what do we do with our patient? So our patient ended up going the transplant. She's septic, and we tested this organism against ceftazidime avibactam and Aztreonam, and surprisingly, it was resistant. And the meropenem MIC was greater than 16, so if you remember, we can't use meropenem if the MIC is greater than 8. And ceftazidime avibactam was greater than 256 in somebody who has never been exposed to this antibiotic. So we had a very smart fellow on service who was like, there is something really unusual here, right? So said, what's going on? Let's figure out what else can we do for this patient. And we were able to do molecular testing, try to figure out what's the exact mechanism of resistance. And to our surprise, this patient had a new deli betallolactamase. It was the first one we had seen in our hospital. It's one of the things that you read in the literature and you think it's never going to happen in your door. And then it also had two other mechanisms. It had an OXA and a CTXM. So what is the significance of all of this? Well, pretty much you lose all cephamycins, carbapenems, cephalosporins, penicillins, and extended spectrum beta-lactamases and your carbapenems. So that's the phenotypic interpretation of your genotype. So what do we do with this patient? Well, we know that different beta-lactams have different affinities to the penicillin-binding proteins. And we know that there is a concept in vitro called synergy. And it means that you can combine two drugs that are resistant, and 2 plus 2, instead of 4, equals 5. You may obtain a drug that is susceptible. So we tested in vitro ceftazidime avibactam plus Aztreonam, and we found a zone of inhibition here called synergy. But when we tested tigacycline, we found that they were antagonistic. So the point here is that you can't just mix any drug and have a cocktail that will work. You really have to test the combination and see if these two combinations will cause a fold reduction of the MIC. So MIC went from greater than 256 to 24, and for ceftazidime avibactam from greater than 256 to 12. So we call this the zone of hope. So to end this, if we keep fighting multidrug-resistant organisms with antibiotics, we're going to keep adding more fuel to the fire. So what can we do to win the battle? And that's my son when he was 2 years old. He's now 10. So we need some brave pirates, but we also need to start thinking outside the box. And what if we could fight these bugs with themselves, with a healthy microbiome? And this is one of our pilot feasibility studies, and we're trying to enroll patients to see if we can give them a fecal transplant enema and repopulate their microbiome and repopulate these multi-drug resistant organisms with healthy organisms that either don't need antibiotics or are now pan-susceptible again. And this has been done in immunocompetent patients, but not in immunocompromised. This French study, they took 8 patients. 6 of them were colonized with Carbapenem-resistant Enterobacteriaceae and 2 with VRE. And they did rectal swabs, they did a single enema, and they eradicated CRE and VRE in 2 out of 8 and 3 out of 8 patients after 1 and 3 months. FMT seems safe with an impact in multi-drug resistant decolonization. The problem is right now you need an IND from the FDA. It's only approved for C. difficile. Any other use of FMT needs to be approved by the IRB and the FDA. So we have an IND from the FDA, and we're in the process of enrolling patients. So take-home messages. Antibiotic resistance is a global problem, but we are all part of the solution. Antibiotic therapy has to be tailored to the individual patient. You need to know your local epidemiology, but also where that patient has been. You need to know what is the source of infection that you're treating, what's the mechanism of resistance of the bacteria, and always think of giving the right drug, the right dose, the right route, and for the right duration. And we need better inventions to proactively preserve and repopulate these microbes. So to end, I think that the world needs dreamers and the world needs doers, but above all, the world needs dreamers who do. I wish you all a happy Passover and a happy Easter, and thank you for your attention.
Thank you, Lillian. That was great. We have time for one quick question. Okay.
You mentioned that inappropriate therapy is one of the risk factors for resistance. Does it make any sense to measure the levels of the antibiotics and be sure that we are achieving the correct MIC when we treat infections with disorder?
Excellent point. So therapeutic drug monitoring. So we do it currently for antifungals, right? We do it for voriconazole, we do it for posaconazole. Can we do therapeutic drug monitor for every antibiotic we do and adjust based on pharmacokinetic properties, right? And determine, are we overcoming the MIC? That is something that in a dream world we should do. Is it feasible and doable? What's the cost and what's the reality of doing it? In some centers in Italy, they're already doing it. And they do personalized medicine. It's precision medicine. You pretty much dose the antibiotics depending on the MIC, depending on the kinetics and the individual patient. Because it's not just the MIC. Some of your patients might be on ECMO and on CVVHD. And we don't really know how to dose antibiotics appropriately. We don't know how any of these lipophilic antibiotics are being retained by the membrane. So, and also we know that patients in the ICU have a different volume of distribution. They're on pressors. So we really need better kinetic studies to try to personalize the dosing of antibiotics. And I encourage Dr. Preston here in the audience to start that program.
Thank you, Lillian.
Thank you.
It is my pleasure to introduce today our second speaker, Dr. Zain Mithani. He graduated from the University of Miami Miller School of Medicine and then went on to complete his internal medicine residency at the University of Colorado, followed by a nephrology fellowship at Cornell University. He has been involved in several research projects, including an ongoing study about early markers for AKI in patients receiving chemotherapy, and has co-authored a number of regional publications. He's currently an assistant professor at the University of Miami Miller School of Medicine in the Division of Nephrology, and today he's going to talk about acute interstitial nephritis. Please join me in welcoming Dr. Mithani.
Hello, everybody. It was good that we had somebody talk about antibiotic stewardship before my talk, because it is definitely a cause of acute interstitial nephritis, so that's good we start with that. So I'll start with a case, just go through it briefly. It's a 52-year-old gentleman, a history of hypertension prior to tobacco use, and had a diagnosis of metastatic extrapulmonary small cell carcinoma of the pancreas. And we were seeing him, obviously, for a rise in creatinine. So just briefly, he was diagnosed in December of 2016. He came in with diplopia, had some imaging done, was found to have an orbital mass, and eventually was also found to have metastasis to the liver and a large pancreatic lesion. He underwent treatment with 6 cycles of carbapenem and etoposide, and then subsequently had 4 cycles of fluoronox and had progression of disease on both these regimens. So ultimately, he was switched over to off-label therapy with nivolumab and ipilimumab. And after he got his second dose of ipilimumab, on routine labs with his oncologist, he was found to have a pretty big rise in his serum creatinine. And so he was sent over to nephrology for further evaluation. Just some other history on him. He was on losartan when we saw him. Everything else we've kind of discussed. And his exam was benign. You know, he didn't have any wheeze, didn't have a rash, didn't have any edema. As far as his data, he did have an elevated BUN in creatinine. His urine electrolytes, he had a urine sodium of 54 and a urine creatinine of 74. His urine analysis, he had 1 plus protein and was dipstick positive for blood. He had 5 RBCs, 11 WBCs, and had some rare granulocysts. He did also have some proteinuria. Fine. So we do what we do when we don't know what's going on. We got a kidney biopsy. And so I highlighted the important part, so you don't have to read the whole thing, but his glomeruli and his vessels were normal. But what was interesting is he had diffuse and dense inflammation of his interstitium with lymphocytes, mononuclear cells, and eosinophils. And so obviously this gentleman was diagnosed with acute interstitial nephritis. And we'll end with his case and talk about maybe the role of checkpoint inhibitors in his disease. So AIN is characterized by the presence of inflammatory infiltrates and edema within the interstitium. It's associated with it usually is associated with an acute deterioration in renal function. As far as prevalence, when we look at all-cause kidney biopsies, so that could be for nephrotic syndrome, it could be for AKI, it could be for hematuria, about 3% of biopsies done for any cause show AIN, and 13% of biopsies done for AKI show AIN. So it's thought to be the second leading cause of AKI. When we look at these biopsy registries, it looks like the incidence of AKI has been increasing over time, but that may be in part because of increased detection. We've become more comfortable in doing biopsies, especially in the elderly, so we may just be picking up more cases. But we do know that there is increasing use of NSAIDs and PPIs, both of which have been implicated in developing AIN. So as far as the etiology of AIN, this is kind of North American, European data, and 75% of cases of AIN are due to drugs. The rest are kind of divided pretty evenly between infections, idiopathic causes, so like TINU, IgG4 disease, and then it could be associated with systemic diseases like Sjogren's, sarcoid, lupus, things like that. When we look just at drug-induced AIN, the big three to kind of remember are antibiotics, PPIs, and NSAID. Those kind of make up roughly a third each, but it should be noted that any drug can cause AIN, so just because it doesn't fall within one of those big three doesn't mean it couldn't be the cause. As far as the worldwide etiology, so in Europe and North America, yeah, they both kind of follow this kind of 80-20 split between drugs and other causes. But when you look at Asia and Africa, it's more of a 50-50 split, where we see 50% of the cause of AIN due to drugs and 50% due to infections. Just a quick word on proton pump inhibitors, because they've had a lot of kind of press recently. We all know PPIs are a very commonly prescribed medication, but the true incidence of PPI-induced AIN is very low. It's just that they're very prevalent. And it's always important to remember, a lot of our patients are on it, but about 50% of patients who are on PPIs are put on without a clear indication, and often prior to therapeutic lifestyle changes. So somebody who has GERD, maybe we should be educating them about caffeine, alcohol, weight loss before we kind of reach for a PPI. The AIN that patients get from PPI is often less severe, meaning that the serum creatinine doesn't go as high, but the probability of recovery at 6 months is less compared to other causes of drug-induced AIN. So I said, kind of the serum creatinine is lower, but often what's happening in the kidney is not always reflected in your actual serum value. It's also important to remember it's a class effect, so patients who maybe had AIN from omeprazole, you can't just switch them to pantoprazole or Nexium. This is different than H2 blockers, so if you had a patient who was on cimetidine, which is of the H2 blockers has the highest incidence of AIN, you can try them on ranitidine or another H2 blocker. And then this is all epidemiological data. The incidence is extremely low, so it's hard to design prospective studies. This is a systematic review that came out earlier this year, and they looked at patients on PPIs and people's off PPIs. So there's about 2.6 million patients they looked at, about 500,000 of whom were on PPIs. And when they looked at the incidence of AIN, AKI, CKD, and end-stage renal disease, they were all higher in patients who were on PPIs compared to those who weren't. And the incidence of AKI, CKD, and end-stage renal disease, when you looked at patients on PPIs compared to those who are on H2 blockers, so, thinking, hey, is there something about patients who have, gastritis, does that put you at higher risk? It was still higher in the patients who were on PPIs. So, kind of rule out the big three. I'm not going to read this list off, but there are obviously other causes of AIN. So once you've made sure your patient isn't on an antibiotic or an NSAID or a PPI, you can start going down the list and kind of checking things off. Pathophysiology. So there's 4 proposed mechanisms on why patients develop AIN after taking a drug. The first is the thought that maybe the drug comes in, binds an endogenous antigen, and forms a novel hapten to which the immune system mounts a response to. It could be a form of molecular mimicry, so you have a drug, the immune system mounts a response to this drug, but it looks similar to an endogenous antigen, so there's this cross-reactivity. The drug can act like a trapped antigen, so it either attaches to the tubular-based membrane or to the interstitium, and an immune response mounts within the kidney, or the immune response can be circulating, you form circulating immune complexes, and then those immune complexes deposit in the interstitium, and then you activate complement there. So diagnosis. So the gold standard for diagnosis is a renal biopsy. And I know we all don't look at kidney biopsies all the time, so I'll just kind of walk through normal, which are these 2 panels here. So you have a nice looking glomeruli, you can believe me. The capillaries are open, the tubules look nice. And the important thing is on these two biopsies, you don't see the interstitium. So on a normal kidney biopsy, you should not see an interstitium. If you compare that to kind of panel 4 here, again, you have a nice normal glomeruli, but now your tubules aren't back to back like they were here. There's a lot of inflammatory lymphocytes in the interstitium. There's a lot of edema. And this right here is this top one right here is an H&E stain. And you can see the eosinophils staining brightly on an H&E stain. I'll skip that slide. So what about other diagnostic tools? What if your patient can't get a biopsy? Maybe they're on anticoagulation. Maybe they're just resistant to doing a biopsy. What are other tools we can look at? So the first thing we kind of all learn in medical school is the triad. This, rash, fever, eosinophilia. I think we all know that this is kind of like a crummy marker for AKI. Each one of them, skin rash, fever, and eosinophils, are presented about a third of patients. But to have this kind of full triad, it's really seen in less than 5% of patients. So it's fine for the test, but you don't really see it. What about the UA? Any patient who has AKI, we always ask for a UA, and yeah, it's true. You'll see hematuria, you'll see leukocytes in the urine, you'll see nephrotic range proteinuria, but these are really non-specific findings. You'll see this in ATN, you'll see this in GNs, and so it doesn't give you a diagnosis of AIN. What about urine eosinophils? We kind of always ask for that when we're concerned about AIN. The sensitivity of urine eosinophils is about 67%. So you're missing about a third of patients if you're looking at. So just to say a negative test, it doesn't rule out AIN. And what about imaging? So CT scan and renal ultrasounds are not helpful. There's always, always on the test, they'll say you have large kidneys because of the infiltration. You don't really see that big of a change in kidney size in AIN. There is a role of gallium scans, so this is good in patients who maybe have a solitary kidney or can't do a biopsy on for some reason. Gallium is injected, it binds to lactoferrin on WBCs, and it'll light up wherever WBCs are. So it makes sense. But the specificity is about 50 to 60% because obviously things like pyelonephritis or GNs, these are all inflammatory processes within the kidney, and so they'll also be positive. Okay, so you made a diagnosis of AIN. You got a biopsy, you have the diagnosis. So what do you do? So I think everybody agrees you got to stop the offending drug or treat the underlying cause. And then sometimes you'll have nephrologists who tell you to treat with steroids, and sometimes you won't. And this has been kind of a little bit of controversy over the last 10 years. So let's look at the data, and then we can kind of decide if steroids should be kind of a mainstay in the treatment of AIN. So we'll go through kind of a timeline. So this is a study from 2004. This was done in Ireland. It was a retrospective study. They had 42 patients with biopsy-proven AIN. They had 26 in the steroid arm and 16 in the no-steroid arm. And they just looked at creatinine at 1 month, 6 months, and 12 months. And there was no difference between the two groups. And so the authors concluded that steroid therapy should not be part of the routine management of AIN. The big criticism of this study was that there was a delay in the start of steroids. So the median delay between the diagnosis of AIN and the start of steroids in these patients was 3 weeks. But if you look at kidney biopsies, once someone has AIN, when you have the interstitial edema for more than 7 to 10 days, fibrosis starts to set in. And so maybe 3 weeks was too long of a period, and you're really, you're kind of missed the boat. That these patients already had fibrosis set in, and the steroids were really just started too late. Fine, so 2008, this is a study from Spain. It was a multi-center retrospective study. That's 61 patients with biopsy-proven AIN. So 52 were treated with steroids, and 9 were in the no-steroid group. And at 19 months, there was a lower final creatinine in the steroid group. So this is 2.1 versus 3.7. And less patients were on renal replacement therapy. And this was pretty significant. So it was 4% of patients in the steroid arm versus 44% of patients in the non-steroid arm. So it's a pretty big difference. It is important to remember that the steroid arm was very small. It was 9 patients. So if you were able to take 1 or 2 of them off dialysis, that's a swing of 10 to 20%. But even a difference of 4 to 20% is still it's still a big number. But what about this thought about early steroid therapy? So what they did was they took patients who had drug-induced AIN due to NSAIDs, and they divided them into 2 groups. They divided them into complete recovery and partial recovery. And so the final creatinine in the complete recovery group was 1.1, which I think we can all agree is pretty good. And the partial recovery group had a final creatinine of 2.4. And they looked at the time to start steroids. And it was 18 days versus 31 days. So there was a significantly earlier start in the patients who had complete recovery. And about a third of those patients had steroids started within the first week. So now we kind of have 2 studies. One that's saying steroids don't help. And now we have a second study saying steroids do help, and probably early steroids are even better. So now we have a third study. This is from the Mayo Clinic. This is 95 patients with biopsy-proven drug-induced AIN. And 83 were in the steroid arm and 12 in the no steroid arm. And this was kind of a mix. So this showed at 6 months there was no difference in the creatinine of the 2 arms, and there was no difference in time to recovery. But a shorter time from AKI to start of steroids was associated with complete recovery. So the group who had complete recovery had steroids started at a mean of 8 days, compared to the patients who had no recovery, who had a mean start of 34 days. So my thoughts. So patients with biopsy-proven AIN, I think it's reasonable to start glucocorticoid therapy if there's not a contraindication. In patients who are high risk of poor tolerance, whether they have brittle diabetes or osteoporosis, I think withdraw the drug, and you can monitor for 48 to 72 hours to see if they start to have recovery. If you're going to start steroids, you should start within the first 7 days. So if you see a patient in clinic, don't wait to the next week to get labs. Get labs later that week and decide whether you're going to start steroids or not. Okay, so moving on to checkpoint inhibitors. So checkpoint inhibitors are a new immune therapy used in the treatment of, initially started for metastatic non-resectable melanoma, but also in non-small cell lung cancer, renal cell cancer, and Hodgkin's lymphoma. And these are monoclonal antibodies that target the immune receptors on T cells, and we'll take a look at them. Okay, so there's two big ones. So there's anti-CTLA-4 and there's anti-PD-1. Anti-CTLA-4 is our ipilimumab, and this acts in the peripheral lymphoid tissue. So you usually have a antigen-presenting cell, has an MHC. That MHC binds to its T cell receptor. That's the first signal. And then there's a second signal. It's the B7 binds to usually CD28, and that activates the T cell. If that B7 binds to CTLA-4, that suppresses the immune system. So obviously, if you block the suppressor signal, that'll activate the immune system. So this activates autoreactive T cells. The CTLA-4 usually plays a role in suppressing autoimmunity. Okay. And then anti-PD-1 are antibodies that block a signal from PD-1 ligand. PD-1 ligand is on like normal tissue, and that tells your body, this I'm self, don't kill me. And so if you block the PD-1 to PD-1 ligand signaling, you keep these autoreactive T cells active. And the thought is that if you're keeping these autoreactive T cells active, they can attack cancer cells. So that's great. But what we've started to see is an increasing incidence of AKI from these checkpoint inhibitors. So this is a study that had 13 patients with a checkpoint inducer-induced AKI, 12 of them who had biopsy-proven AIN. And 10 of those ended up getting steroid therapy, 9 of whom got better. None of the patients who did not get steroids got better. This is a second case series. These are 6 patients with biopsy-proven AIN on checkpoint inhibitors. 5 got steroids, 1 didn't, all got better. 1 was re-challenged with checkpoint inhibitors, and it did have recurrent pretty severe steroid-responsive AIN. So what's kind of the point of all this? So I think what's interesting about this is it points to a proposed mechanism of how AIN works. So 14 of 18 of these patients were also on medications that are known to cause AIN, like commonly associated medications like PPI and NSAIDs. The other 4 were also on medications, and it's important to remember, just because you're not on one of the big 3 or classic medications, any medication can cause AIN. And so it could be that checkpoint inhibitors act like NSAIDs or PPIs, and you just mount an immune response to the checkpoint inhibitor, and you get AIN because of that. Alternatively, it could be that checkpoint inhibitors, because they downregulate T cell, or because they're activating the immune system of previously downregulated T cells, it could be that T cells are playing a role in the pathogenesis of AIN. And that's why some patients can be re-challenged with checkpoint inhibitors, like the patient in our case, and don't develop AIN. And it also means that maybe the treatment of AIN should be focused on targeting T cells and not just blanketed steroids. As far as checkpoint inhibitors and AIN, steroid therapy appears to be safe, appears to be effective. 14 to 15 patients who got steroid therapy had at least some response, complete or partial, and only one of the 3 patients who did not get steroid therapy had recovery. And it's also important to remember that steroids aren't benign. One of the patients in their study did have a pretty severe steroid myopathy. So back to my case. Pathology results came back. Patient was diagnosed with AIN. He got pulsed with methylprednisone, and then he was transitioned to oral prednisone for a 4-week course. His creatinine came down from 4 to 1, and then he was able to complete 2 more doses of ipilimumab, and now is on nivolumab monotherapy every 2 weeks, and didn't have any recurrent AIN. So I think this kind of points to the idea that maybe it's not the checkpoint inhibitor itself that's causing the AIN, but it's regulation of the immune system. My thought on this was our patient was on losartan, and losartan, there are obviously case reports of losartan causing AIN. The losartan was never restarted in this patient, and I wonder if the patient was somebody who had AIN due to losartan and really just needed the immune system to be revved up for it to be seen. So just a summary, it's important to remember the big 3 causes of AIN, the PPIs, NSAIDs, and antibiotics. But there are other causes, and you can always kind of go back and look at the laundry list. Diagnosis, renal biopsy is the gold standard. But and it's important to know the utility of other studies like UA, urine eosinophils, and imaging. It's important to know the role of steroids in AIN and this new association of checkpoint inhibitors and AIN. Thank you.
That was great. Thank you very much, Dr. Hoffney. Is there any way to predict which patients, when re-challenged, will still have an adverse reaction, or you just follow them very carefully?
Yeah, you follow them pretty carefully. I mean, the problem with the checkpoint inhibitors is they're very effective. And so, they've increased survival in patients with metastatic melanoma from like 6 months to 10 months. So, I kind of had this question for our oncologist, and he was kind of like, "What? I'd rather re-challenge and have him have AIN than him,
Dying
and have
of cancer.
Yeah, so.
That's their approach. Yes. Oh.
Ah.
Checkpoint inhibitors are usually oftentimes given in the setting of metastatic lung cancer or refractory Hodgkin's disease.
Right.
And you oftentimes don't have many more choices.
Right. Exactly. Exactly.
From a biologic standpoint, one of the things that there are two issues here. You can get rid of the AIN with the steroids, but that may attenuate the checkpoint inhibitor. And there isn't good data yet.
No, that's true. There's a
One of the things that we've done is that we'll go to every 4-week dosing, and we'll find that the creatinine kind of fluctuates as opposed to getting right on the 2-week dose. Some sort of
while on steroids, or
no, also.
oh, okay.
Barry.
Excellent. Our patients rarely tell us about the herbal or folk medications they're taking. Any clues as to which of these is more likely to cause AIN than others?
Well, I kind of skipped over it, but one of the kind of the big causes is this aristolic acid, this Chinese herbal nephropathy, was the cause of the bulk of nephropathy. Patients on weight loss drugs, those are classically associated with or contaminated with aristolic acid. But it's important, any drug can cause AIN, so it's not. It's hard to say, one causes it more, but that is one that's been classically associated.
I want to thank both our presenters for great grand rounds and look forward to seeing you all next week.